Ladies and gentlemen, it's a great pleasure of me to introduce Dr. Stanley Lam. Dr. Lam is a musculoskeletal sports and pain physician from Hong Kong. He is a clinical associate professor of the Chinese University of Hong Kong, the president of the Hong Kong Institute of Musculoskeletal Medicine, and the founding president of the MSKUS Asia Pacific. I think he has a very strong connection with Taiwan, so he is also the honorary consultant of the Taiwan Association of Protherapy and Regenerative Medicine. So I think he's not only our invited speaker, he's also our good friend. So today he's going to talk about ultrasound techniques for suboccipital headache. Let's welcome Dr. Lam.
Thank you, for your kind introduction. Thank you, the Taiwan Society of Neuromuscular Medicine, for the invitation for me to share with you the ultrasound techniques for suboccipital headache. It's really my honor and pleasure to be here again. In fact, I was here two weeks ago, and there was a typhoon. And this time, 2 weeks later, typhoon again. So I think I really bless all these two typhoons are not hitting Taipei that much, and we're safe. I have nothing to disclose, and I have to dedicate all my lectures to my God and to my Father in heaven and to my wife for their continuous support and keep reminding me to be a righteous person. And to all my teachers, including those science teachers, for sharing with me those knowledges I'm going to share with you right now. And also to all my patients, even I'm only in Hong Kong about 2 weeks per month, they still come back and wait for me to treat them. And that's thank you, thank to all these people, and also to all of you here, and for paying attention to this lecture. So today I'm going to cover the sonal anatomy of the suboccipital region. I have to say this is not a very easy area to go through, and if you don't have very good needling techniques, do not put the needle in this area. I'm going to tell you very soon why. And I'm going to cover the muscles and ligaments, and also the nerves, the greater occipital nerve, the lesser occipital nerve, the third occipital nerve, and suboccipital nerve in this region, and also the cervical facets. So pay attention to the C01, and then I'm going to cover mostly the C01 area and also the C12 area. And then the home area, the home muscle, or the home view you need to get before you can scan a very good, and you can just trying to figure out what structures you're looking at, is the obliquus capitis inferior. So which is coming from the C2 spinous process all the way to the C1 transverse process. And then covering on top of it, you have your semispinalis capitis on the medial side, and also a little bit on your lateral side. You also have the splenius capitis, which is covering the most lateral part of it. Also remember, most of the atlas, they are not very correct in talking about the longissimus capitis, which is the immediate muscle covering the lateral part of that obliquus capitis inferior, so OCI. So this muscle is not that small, it's very big. In fact, it's the superficial layer right on top of the OCI. It is pretty much the medial edge of the longissimus capitis is where you can find your greater occipital nerve. So this is the muscle I'm going to talk a little bit more. And also when you're looking at, that's the longissimus capitis I was talking about. So when you scan the long axis of your obliquus capitis inferior, you're going to see on top of it your longissimus capitis. And also when you're scanning the C2-3 facet, you're going to see that the splenic surfaces is really covering that on top of the third occipital nerve. So that's the muscle we frequently forget. In fact, we're seeing it when you're trying to do the intervention on the third occipital nerve or the C2-3 facet. You are doing the injection all the way through that muscle, and that muscle is not small, and it's big as well. So, and then also another landmark, you probably see it, but you don't know it. It's the most superficial layer of the muscle, the upper trapezius, very thin over the suboccipital area. And also the SCM, also very thin. And then especially the SCM, if you want to see the entrapment of the lesser occipital nerve, which is on the medial side of it, and it's also going through the inner part of it. So that's the home position. And also the nerves we are going to talk about is the greater occipital nerve here, the lesser occipital nerve, remember, is wrapped around the longissimus, and also going in between your splenius capitis and also your SCM, sternocleidomastoid muscle, to surface the skin. And also the suboccipital muscle, the suboccipital nerve. This nerve supplies all the four muscles, the obliquus capitis superior, the inferior, and the rectus capitis posterior major and minor muscles. So if you look at the atlas, most of the atlas will let you know these nerves trying to surface from the underneath your the obliquus capitis superior, and it going on top of the rectus capitis posterior major and minor. In fact, for a nerve to supply an area, there are branches going above it and going below it. So when you look at those muscles, the muscle fascia outside the nerves, basically you are seeing the nerve, the suboccipital nerve. It's basically surrounding the muscles and then surrounding the muscles. So remember that you're looking at the fascia, looking at the layer above and below it. And also the third occipital nerve, which is usually when you look at when you're trying to do intervention on greater occipital nerve, in fact you are trying to do a lot of intervention on the third occipital nerve at the same time. Why? Because usually this nerve is traveling together with the ascending cervical artery, really trying to supply that C2-3 facet, and they're trying to surface underneath your obliquus capitis inferior and to meet the greater occipital nerve on top of the rectus capitis posterior major, which you are going to see very soon. Okay. And also one artery I want you to pay attention to is the vertebral artery, which is usually, you know that the C1 transverse process is going to go through it. But you know that when you look at the C1, you're not only seeing the vertebral artery before it becomes the circle of Venus. You're also seeing the ascending cervical artery, which is anastomosing with it. And you look at the occipital artery. When you look at the occipital arteries, wrapping around the longissimus capitis muscle over the insertion, you also seeing the deep cervical artery, which is really branching and then anastomosing with that. So those are the arteries you're going to look at when you're doing the ultrasound. In order to have a very good technique and to have a very good view, I urge you to have the machine should be, you need to have a narrow probe. The probe should not be wide. Why? Because if the probe is too wide, you're going to have a lot of volume averaging. You're not going to see the structure very clearly, especially during the intervention. If your probe is too wide, means too thick, and then you are going to not to see if you see the needle, and then your needle can have a lot of volume averaging and then hitting the surrounding structure, but they look not on the same plane. And also, when you look at the home position, remember you're seeing this is the C2 spinous process. That's the transverse process for C1. And this is the deep cervical artery trying to anastomosing with the occipital artery. And this muscle, the big muscle here, was the muscle I was talking about, the longissimus capitis. It's a big muscle, not a thin muscle. And this is the splenius capitis. You have SCM. This is the the lesser occipital nerve, and you also have your upper trapezius muscle, your splenius capitis, your semispinalis capitis, and this is your greater occipital nerve on the medial edge of your longissimus capitis. And at this level, you are going to see that one of the branches of the ascending cervical artery is going to meet the vertebral artery really underneath that, the obliquus capitis inferior. And guess what? This is also the C2 nerve root is really right next to it. And your third occipital nerve is also going to travel underneath your obliquus capitis inferior and wrapping around that muscle, and they're trying to surface on top of it. So you're going to see that in very soon. And this is the area where you're going to have your C2. Now you go starting from the home position. You try to pivot the lateral end of the probe, and then you pivot the medial end of the probe upward. Now you're going to see that the most superior edge of your obliquus capitis inferior, and then you see another muscle coming in from C1 to occiput. That is your obliquus capitis superior. And then looking at this artery right now, this is already the artery going to the together with the C1 nerve root, and that's your rectus capitis posterior major. Let's look at that again. Pivot the medial end of it upward. You're leaving the C2 spinous process very soon. When you're leaving the C2 spinous process on the medial side, and also there's another thing I want to remind you is on the medial edge of your obliquus capitis inferior, you also have a dural bridge. Okay, so this is the artery going together with the third occipital nerve going to meet the greater occipital nerve on top of the rectus capitis posterior major. Rectus capitis posterior major. And then this muscle here is your superior oblique, obliquus capitis superior. And then the muscle on top of it, here you have your longissimus capitis. This is a big muscle, not a small muscle. And then you have your splenius capitis. You also have your SCM. And then this muscle here, in between the two muscles, you have your lesser occipital nerve. Once again, if you want to go from this, if you want to go from the obliquus capitis superior, and this is the rectus capitis posterior major, longissimus capitis, this time you keep going cranial. You're going to see the occipital artery is trying to wrap around that over longissimus capitis. And you have your insertion of your superior oblique, and you have your insertion of your splenius capitis, SCM, and the most medial end, you're probably going to see upper trapezius. And this time you're trying to go also from the, you're going to see that I'm trying to see from the obliquus capitis inferior, and I'm going to do scanning upward, and you're going to see the medial edge of the obliquus capitis inferior, and then see the rectus capitis posterior major, and you see the superior oblique longissimus capitis. This time I'm going a little bit more medial, and you're seeing the rectus capitis posterior minor, semispinalis capitis, and the upper trapezius, a thin layer on top of it. This is more medial. Now I'm scanning from the middle, reading on the midline, upper trapezius, a very thin layer. You see the semispinalis capitis, two bundles, medial bundle and the lateral bundle, rectus capitis posterior major, and you see the rectus capitis posterior minor, and then when you're seeing that the C2 spinous process, the vivid spinous process, you see the arch of that posterior arch of the C1, and you see the C2, the bifid spinous process on the midline. Let's do that one more time. Semispinalis capitis. I'm scanning down. On the most medial side, you're seeing this is a rectus capitis posterior minor, minor, major, major. You see the C01 joint with a ligament, C01 ligament with joint, and also you see that the posterior arch of your C1. And remember this artery is going into the brain, and you see that the C12, the space, and it is the bifid spinous process of C2. This time I'm trying to do, what I'm trying to do is coming from the midline, and I'm trying to scan more lateral. Let's do that again. Rectus capitis posterior major, you're scanning more lateral, and then you are going to see the obliquus capitis inferior. This is the dural bridge I was talking about. This is the dura and the epidural space. And then you're seeing that this is the rectus capitis posterior major, and you're seeing that the suboccipital nerve is basically above and below that rectus capitis posterior major. And at this level, the fascial layer on top of the rectus capitis posterior major, you are seeing the greater occipital nerve, the lesser occipital nerve, and the third occipital nerve. It's basically really over this fascial layer, and the semispinalis capitis on top of it, and the upper trapezius. And if I go more medial, this time you can see that after seeing the spinous process, one of the bifid spinous process, and then you're seeing the rectus capitis posterior major, and the minor is really coming from the occiput all the way to the C1. This is, if you're seeing that, the rectus capitis posterior major from your C2 spinous process without seeing the obliquus capitis inferior, this is where you are going to see your rectus capitis posterior minor. If you're seeing that the obliquus capitis inferior, you're not going to see the minor at that level. This time I'm trying to do that from the midline again, and then you're seeing that this is the major, and you're not seeing the minor now, and then you're seeing the obliquus capitis inferior, and you're seeing the major, and then very soon you're going to see your this is semispinalis capitis, and then you're going to see your obliquus capitis superior, and this is the dural bridge I was talking about, and if the obliquus capitis superior, and right now when you see the superior, now you're seeing the longissimus capitis really on top of it. This is longissimus capitis, and then you're starting to see the semispinalis capitis. And if you keep going more lateral, after seeing the transverse process of your C1, the next muscle you're going to see is the rectus capitis lateralis. And the more lateral, when you're seeing the parotid gland, underneath you'll see the digastric muscle. So this time you're seeing the major OCI, and you see the artery going on top. This is C1 going together with the C1 coming out, and the C2 is coming on below the OCI, and you're still seeing the major your semispinalis capitis, and soon when you see the longissimus capitis, you see the splenius capitis on top of it, your OCS, and you see this is the rectus capitis lateralis, and when I see the parotid gland on top of it, and then I'm seeing the digastric muscle on top and below it. This is from more medial and then all the way to the lateral. And then you're starting to see your external carotid artery as well. So greater occipital nerve, those are the muscle or the landmarks. In fact, I have shown you, apart from the scanning those muscles, you're also seeing these some of the nerves already. I've talked about those nerves, but I still want you to see. This is below your OCI. You have your C2. You have a C2 nerve root coming out, and then it's trying to wrap below that the OCI. You see the long axis of this greater occipital nerve right here. It's going up. So I'm scanning up now, and then you're seeing that the GON is really on top of it right now. So this is trying to let you see from the nerve root and then wrapping around that OCI. This time I want to go from the short axis view and then trying to rotate the nerve, the probe, and then want you to see that the long axis of the greater occipital nerve. Now this is the OCI, and this muscle here is the rectus capitis posterior major, and then you're going to see that this is where you're going to have your greater occipital nerve really trying to puncture through that semispinalis capitis and the upper trapezius. This is where the entrapment point. Entrapment point is right here, it's not here. And then this is also the level. When you see can you see a blood vessel? It's really on top of you, superior to your OCI and inferior to your rectus capitis posterior major, and then that's where your third occipital nerve coming out, and it's trying to circle that. Maybe I'll show you it once more with this. When this nerve trying to turn this from the short axis to long axis, and then really below it you see the C2 nerve root, and you're going to see at the same time you can see that the C1 is really here, and then you can see that this is the nerve coming out, the third occipital nerve trying to go underneath your OCI and then trying to surface and then to meet the greater occipital nerve. And the greater occipital nerve, the entrapment point is really when they puncture through that semispinalis capitis. Oh, this is pretty much the same. And then that's from the GON, I turn to the long axis. You can see that it's wrapping around from C2 and going up, and this is the artery going together with the third occipital nerve, and now it's trying to go and then be in caudal to that OCI, and then now you're seeing that the C2 3 facet, and this is the deep cervical artery really, and then there's ascending cervical artery on the lateral side and the deep cervical artery on the medial side. The lesser occipital nerve, remember it comes together with the greater occipital nerve from the dorsal rami, but it's going to surface, wrapping around that the longissimus capitis, and also trying to go between the SCM and splenius capitis going up. So it's basically there are several entrapment points. One is between the SCM and the splenius capitis. The second one is between the longissimus capitis and also the splenius capitis. So those are the two entrapment points, very important one. Third and least occipital nerve. This is the C2 coming from the C3, and this is coming from the C3. It's trying to supply the C2-3 facet, and this is when the greater occipital nerve is leaving inferior to that OCI. This nerve is trying to sneak through and underneath the OCI and trying to meet the greater occipital nerve. And when you see the rectus capitis posterior major, so this is you only see the major now, and this nerve is trying to surface together with your GON and then to go into surface on the really midline of it. I have to be quick. So the third occipital nerve now, you see that it's trying to sneak through underneath and then trying to surface between the major and the OCI. Okay, suboccipital nerve. Basically, I try to scan from the digastric muscle here, and then the external carotid artery, and then trying to surface. This is the occipital artery, and then they've seen that the rectus capitis lateralis, and if I'm scanning more medial, you see the OCS, and you see the OCI, and it is when you see the OCS, this is the C1, and it comes out from the C1, and then trying to surface, and then wrapping around all those muscles, the suboccipital muscles, and you see the rectus capitis posterior major here, and it is above and below it. So intervention. All the structures I have talked about, the nerve, and also the facets, and also the muscles can cause the pain over that region. So to do the intervention, if you want to do a GON block, basically the easier way is you can come in from medial to lateral and really on top of the OCI, and then it's trying to really get your needle and then the fluid around that bubble of the GON. But remember, small volume. If you put a lot of volume, you're going to block the lesser occipital nerve and also the third occipital nerve and the suboccipital nerve all together. Okay, small volume. This is if you want to say I don't care. Okay, GON, LON. Okay, then you can come in from medial to lateral and then all the way from here and trying to have your needle. Apart from doing the GON, you can go all the way to your the T1 transverse process, and then you can cover all of it. And you can put more volume for that, and you can basically you get this the SON as well, suboccipital nerve as well. So this is just basically a blocking technique. Or if the patient is really you're trying to put the cryotherapy or radio frequency, you can do that here. But if you really want to do a hydro release or hydro dissection, which is where the entrapment point, you have to go to the semispinalis capitis. You have to go to between the rectus capitis posterior major and semispinalis capitis, really doing in the long axis view. And then you can do from the basically from the if you want to do that from the greater occipital nerve and then to a third occipital nerve, you can also get coming from the from posterior to anterior. And this time you really have to do this C2-3 facet. And then to do that C2-3 facet, and when you're injecting the C2-3 facet, basically you are hydrodissecting that entrapment. But this is if you really want to get the entrapment point, which is over the C2. And then you have to turn the probe 90 degrees. This time you have to see your needle is really on the C2 part. It's not on the C3 part. Okay, so this is C2-3 facet gap, and this is the OCI. SON, basically your needle coming from cranial to caudal. You can go deeper to your, this is the occiput. You need to have your needle all the way going down to the occiput to get to the most entrapment point of the suboccipital nerve, which is underneath your minor and underneath your major. Okay, for time's sake, I'll just keep going. And this is also another one. You're trying to go from, I'll make it quicker. You can basically coming from deep and to superficial. Just make it quicker, okay. Next. For the C2-3 facet posterior approach, simple. Basically more like your TON injection. I will be quick. Basically it just goes posterior approach. you really, this is your, when you see that your major and your rectus capitis posterior major and OCS, obliquus capitis superior, and your needle is coming from posterior to anterior, and when you see the vertebral artery, basically you're hydrodissecting the vertebral artery. Push away the vertebral artery with the fluid, and then you can get your C1 nerve root. You can see the needle tip is pretty much over the C2 and C01 facet. Posterior approach, pretty much the same. You can see that the major here, and your OCS, obliquus capitis superior, and your needle coming posterior to anterior, and you validate your needle tip by turning the probe 90 degree, and you're trying to push the blood vessel away. For this okay, I will just skip that one. The lateral approach is for the C01 facet. I think is the approach I like a bit more. And then I will coming from the lateral to from the lateral side. The needle is really going between your OCI and your OCS, and you're hydrodissecting, and then have a longissimus on top of it. You hydrodissect this area, and you're trying to have your needle keep going, and then pushing all the structures in front of the needle away, and then you can get your needle really close to your C occiput, your C naught. And when your needle going really at that level, you have to turn your probe 90 degree and then walk your needle down from using the outer plane technique, and then go to the C01. Okay. Let's make it quicker. I really don't advise you to do this technique if you not have a very good needling technique. This is important. I think I have to show you here. This is where you're going to see the needle tip going to the joint, and validate again with the needle turning 90 degrees. Okay, that's for the time's sake. Keep going. And for C12, we have posterior approach and also the lateral approach as well. This is the second last. Okay, your needle coming from posterior to anterior, really underneath your OCI. And at this point, you have to turn the probe 90 degree, and you have to make sure your needle tip is really not hitting the nerve root, and is trying to hit the posterior part of your C12 joint posteriorly here, and then you turn the probe again. Now you're seeing the needle really injecting. So you can see that I keep checking outer plane and in plane again and again. And then also injecting with a volume, and then trying to push away the nerve root. Okay, last one. Lateral approach for the C12 facet. There is a window between your your ascending cervical artery and also, there is a window between your ascending cervical and also your vertebral artery, and also another one is the vertebral artery, and this is where you can put your needle really laterally and safely over the C1 and C2. Now I turn the probe 90 degree. This time I'm trying to check my needle position is really over the joint here, the joint right here, and that's the C12 facet, and this is already the C2, and now I'm trying to using this is oblique approach, and then I back to my outer plane technique, and then I put my needle really over that C1-2 facet, and then injecting with volume. And then basically, I don't advise you to do injection if you cannot, see your needle tip very well and all the time when you're doing this intervention technique. Okay. Once again, if you're interested to have some of this technique, you can come to Hong Kong and join us in November 2nd and 3rd. And I welcome you all to Hong Kong. Once again, when I agree to present this topic, I don't advise those newcomers to this to musculoskeletal ultrasound and then doing this interventional techniques in this area. You can scan it, of course, it's safe. Scanning is safe, but to do intervention, I still urge you to have very good needling techniques. Thank you very much for your attention.
Thank you again for your wonderful speech.